Okay, next, let's look at the anterior lateral talar palpation test. We use this one if we're trying to figure out if a patient's presenting with a lateral ankle sprain. This can be used to assess the calcaneofibular ligament. It can also be used to do the anterior and posterior talofibular ligament. So the first thing that we're going to look at is the anterior talofibular ligament. So we're going to do plantar flexion. You're going to grip the calcaneus, and we're going to do calcaneal inversion. Now, if we wanted to assess the other direction, we could go plantar flexion of the foot, dorsiflexion up, and then inversion and eversion. So this combination of motions will let you assess the anterior and posterior talofibular, where the talus and the fibula attach together, this side of the ankle. That's why we do the inversion component. And then we can also do the calcaneofibular ligament, which is the posterior side here, where the calcaneus and the fibula come together. So the directions of testing, whether we are in plantar flexion, inversion, dorsiflexion, inversion, eversion, will also let us know if we have deltoid ligament involvement. So we're looking for any kind of laxity. Now, if you have an acute ankle sprain, they just rolled it yesterday, ankle's huge, discolored, angry, this is going to be a very challenging mobilization to do due to guarding, swelling, edema, and pain. So you may have to give it a few days after the initial injury. But if you are seeing them as a primary provider in rural care settings, this is a great way to screen to determine which ligaments could possibly be involved. I also do want to look for any excessive hypermobility. So my husband does not have hypermobile ankles when we come into inversion on this side. He does on this side because he's had multiple ankle injuries. This side, his joint integrity is good, so I don't have a lot of excess mobility. Now, if you're working with someone who has tears in these ligaments, you will see a considerable deviation. The ankle will feel like it's floating as you're doing the mobilization. I think this is him telling me to give you the bad ankle. So we'll be much more gentle with this one. So if we were going to go into plantar flexion, inversion. So you can see there is a considerable deficit here in the amount of inversion compared to his right leg. His right ankle is nice and healthy and stable, but this left leg is not. He has a considerable amount of inversion. He had a pretty catastrophic injury about 2 years ago running with one of our dogs and ended up with some bone marrow edema. So if you're just seeing a lot of laxity, floating, or looseness in the joint, that would be a positive finding. Now if we compare to inversion on the good side, we do the same thing, plantar flexion, inversion, not a lot of mobility. So his ankles are vastly different. This is why it's also important to screen bilaterally. Even if you're seeing them for this ankle, you want to compare bilaterally. If they're both hyper or hypomobile, may just be the patient's norm. But as with my husband here, he has one that is excessively hypermobile. And this one, when we think about plantar and dorsi, he's almost hypomobile. So they're very different infills and very different mobilization ranges.